here to welcome you to the October 19th kickoff of our goals and interventions focus for the domains we've covered over the last pretty much 9 months. We'll be focusing on really just a roadmap for the work going forward, and then going through some other specific updates. My name is Sarah DeSilvi, for those of you who have not attended a call before. I am the Director of Clinical Informatics for the Gravity Project, and it's my honor to be here today. Next slide, please. We want to welcome you all. Due to the large number of attendees, all participants are muted upon entry. We ask that everyone remain muted to avoid background noise. The call and every call we have is always recorded so it can be referenced on the Gravity Confluence after the call. We do encourage active participation in the call. For those of you who have attended calls in the past, you'll know that I do try to integrate any kind of comments we hear on the chat to make sure we're all of our voices are heard. Do please send any chat comment to everyone so that everyone can see it. And again, I always do a caveat: if you're trying to communicate to me personally, I cannot distinguish between everyone and personal comments, so I might just read it out loud. So if you have something specifically or thought you want to send to me directly afterwards, please feel free to do so. Next slide, please. This is our standard antitrust practices slide. It's just making sure that everyone who participates in the calls knows that we have the responsibility to comply with federal and state antitrust laws. Next slide, please. This is a comment on Gravity Project. Oh, am I breaking up for everybody? Yeah, let me see if I can get a better.
Yes, you are.
All right, let me see if I can get a better connection by moving closer to the router. Is
That's
this
old
better?
School, Sarah.
I know. This is Vermont. Is this better for everybody?
That's better. Thank you, Sarah.
Yes. Thank you.
Yeah, this is the hazard of trying to work in the office, is no one can hear me. All right, so thank you so much for letting me know. So if you've not already done so, we invite everyone to officially join the Gravity Project. You can find that at the Confluence link. Again, you'll be seeing all of the links that we're talking about throughout the presentation will be dropped into the chat for easy reference. We do want to state, we've known this before, that you might have to click the link twice because of the WebEx proxies. If you want to check whether you've already signed up or if others from your organization have signed up, please review the existing membership there. And then for any other Gravity Project information, you can access it on the Confluence, which is just full of so many things. And so that's that last link. Next slide, please. A huge thank you, as always, to our growing number of project founders, grantors, and in-kind supports. As with all social justice work, it's really many hands make labor light. So some folks volunteer their wisdom and expertise. Some folks volunteer and give us and help us support with monetary supports. It's really just an all hands on deck, and we're just very, very grateful. Next slide, please. We are a sponsorship-driven organization, so the Gravity Project's currently seeking additional sponsors to look forward into the 2022 operations. If you're interested in learning more about sponsoring opportunities, you can send an email to gravityproject@emiadvisors.net or visit the sponsorship page on the Confluence site. Next slide, please. So it's going to be largely the Sarah show. So it's going to be me through announcements, updated project schedule and overview, and then we'll go into the social connection, elder abuse and demographics, goals and interventions kickoff. Then we'll pass the mic to Mark, who will give us a policy update. Then Bob will give a technology update. And then I will close with community homework and next steps. Next slide, please. So for announcements, so first of all, we always want to invite everybody to the HL7 Fire ID public meetings. They're kind of a sister to this meeting. They occur Wednesdays from 3 to 4 p.m. EST. We do want to recognize the Sync Health Annual Conference that's happening on September 20th to 21st. Just a huge thank you to Sync Health in general and all of their support and collaboration over the last year. It's been wonderful to become dear friends with that organization. It's they're definitely leaders. Jamie Blandis won an award at the Chic Conference recently. So again, Sync Health's annual conference is September 20th and 21st. A note on the, Evelyn, do you want to speak to the Congressional SDOH caucus, or can someone speak to that who's on the call?
Sure. Hi, everyone. Sorry. So just for us, we just want to alert you to the announcement that there's a current RFI regarding establishing an SDOH focused caucus at the congressional level. So we're just announcing it. They're asking us to share. So within your jurisdictions, if you're interested in contributing to what's happening, for those not aware, there's a lot of legislation on the floor right now regarding social determinants of health, some of it particular to data sharing, interoperability, creating capacity at CBO level. So all the items we discuss as a community all the time. So you may be interested. So it's just an FYI for you all. Gravity Project is not directly supporting it, but we want to make sure you're all aware. Thanks, Sarah.
Lucy, did that address your questions?
Yes, thank you. Who chairs that?
It's bipartisan. It's on the page. So they have different, I'm not looking at it right now, but you can see there that who are the members
Great.
involved.
Okay, thank you.
We do try to give more thorough explications about each of these updates on the Confluence page. So when you land at the Confluence page, there's a lot of other elements there's a lot of other details on the Gravity announcements page. And then Lisa has a nice comment. I wanted to ask about what we can do to start working with Gravity to address CCDA representation of SDOH data elements. As you know, USCDI v2 is going to cause us to need to address all this vocab and data representation work in CDA as well as FHIR. So I'm going to let both Mark and Bob actually comment on that, because I believe I remember an email regarding that. And so we have a meeting scheduled, patient care work group on Monday, 8/23 at 5 p.m. We can try. So Lisa, this will either be an email follow-up or a specific mention later on the call from Mark and Bob, but I promise that we will address your concerns. And it's nice to see you, Lisa, virtually. Next slide, please. We just wanted to give some announcements specifically regarding terminology. We do talk about a lot of terminology build in the terminology section, but we've been getting a lot of questions regarding the deliverables, the products we're producing over on the terminology side. So I'm just going through LOINC, ICD-10, and SNOMED CT. There's a lot of food and security screening tools out there. All of the USDA food security tools are in the ecosystem. WeCare is in the ecosystem now in queue, waiting for the very imminent release. Are the Children's Health Watch Housing Vital Sign, and we focused on developing all of the comprehensive national standardized tools, so they will be coming shortly as well. As everyone's aware, we submitted our ICD-10 SCM request to the Coordination and Maintenance Committee last year. It was heard in March. There's a release of food and security and housing terminology in October. We're incredibly excited for that. And then we will be presenting at the September ICD-10 Coordination and Maintenance Committee meeting on some of those remaining concepts and codes. So there will be another update to some of the concepts after the September meeting that we can tell you at that time. So SNOMED CT, almost all of the food and security data elements are live now and in the ecosystem. They were released in March, and then we just are completing, or they're just completing, a summer authoring period. In September, the majority of our housing instability and homelessness and inadequate housing codes will be in the ecosystem. And we're focusing right now on all domain diagnosis build across all of our past domains really trying to make sure that we're balancing US build with international use, because whenever possible, we try to streamline and build in both places at once, because Gravity really is leading this work on an international level as well. Next slide, please. What I just detailed in kind of specific, we have created a new section of the Confluence within the terminology division that has updated spreadsheets after any relevant coded release for every domain. So this is the way for users and systems and future piloters and current implementers to access live code. So even though some of the code we just talked about is coming, like IC10CM codes and SNOMED codes, those codes will not ever be represented in these sets until they're really in the ecosystem. So after the SNOMED CT release, we will update. After the ICD-10 release, we will update. After every release from registry with new LOIC codes, we will update. This is really to try to get codes to the people. And it is, again, found in the terminology division under a title of SDOH data elements and status. We described this in the past, but when Gravity is not always building new concepts, like in some areas, there's existing terms in the ecosystem that we can have in our data sets that are already there. For example, the codes from some of those comprehensive screeners, like Prepare or the incoming AAFP tool or the Accountable Health Communities tool. So in some instances, there is already terminology there, even if our formal build process is yet to happen or is in progress. So if there's select codes present, you'll see that there is in that column comprehensive list of codes. When almost the complete set of everything we asked for is ready, you'll see it move from select to comprehensive, and there's hyperlinks available to the Excel spreadsheets on the far right. Again, we're really trying to make sure that we get people product to use, and I'm really glad Lisa is excited about it. So again, a couple updates coming shortly after the SNOMED CT release and the ICD-10 release, and then we will be have even more robust information to give you. Again, specifically, almost comprehensive, at least pretty much comprehensive across the housing concepts, given our work with SNOMED CT this spring. Next slide, please. So Tom, is there any interest in adding the 2.1 LA taxonomy codes to the intervention section? We are working, I would say there is interest. You'll see that in our conversation regarding how we approach the interventions build. Right now at this time, we are indirectly mapping to 2.1 LA, like with intention we're doing that, but we do anticipate more formal mapping to community taxonomies in the future. So we haven't done that yet because we're really specifically trying to focus on getting the health information terminology out, but we do build to it, as you are aware. And I'll speak a little bit more to that in a second. Sorry. I hope that answered your question, Tom. So you'll see more, I think, more of what we're talking about when I get to the goals of the goals and interventions work.
Thank you.
Project schedule and overview. So next slide, please. So this is the Gravity 2021 roadmap. You can see it's on all of these slides. The slides got an update over the summer, so this is now the Gravity slide deck. You can see the terminology division. Here we are in August, kicking off our social connection, elder abuse, and demographic elements. And then Bob will talk about the status of the technical division, and we're planning and getting ready for the pilots to begin later on this fall. I'm going to go into a little bit more depth in a second regarding changes to the terminology roadmap and why, but this is the integration of all those three different sets. Next slide, please. Any questions? All right, okay, next slide. Okay, so first of all, you'll recognize these interspersing slides, these kind of transition slides from our Gravity website that's in development. So this is the base page of our website that we worked on with our colleagues at Spire, which is a collective effort itself, trying to represent all the different stakeholders and individuals that are part of the Gravity project. Next slide, please. All right, so now I'm going to go into that in-depth look about why things have changed a bit. So first, you're going to see on the bottom, we do try to anticipate and talk about on the bottom, this black bar on the bottom, you can see there's a triangle and a star and a diamond. So those all correlate to some of those release dates I was talking about on the updates page. So like when ICD-10 CM released and when SNOMED is released. In the domain selection, there's been some changes. You'll see that food deserts and neighborhood safety are no longer happening this fall. And there's a really kind of practical consideration about why that is. So in our work with SNOMED CT, we are still kind of figuring out the best place to build some of those community level terms. So given that that work is international work, really about where in the taxonomy some of these community concepts belong that aren't necessarily physically identifiable to the person, we decided to pause the food desert and neighborhood safety elements until we really knew we had a place to build them within SNOMED CT, since that's a very significant area for our terminology build. And quite frankly, we also just have a lot to do. We have to do goals and interventions work across social connection, stress, elder abuse, intimate partner violence, unemployment, education, and veterans from now until really the holidays, which is the first week of December. So for right now, we're just kind of pausing on our food desert and neighborhood safety elements to really make sure that we have our future location of these terms in SNOMED CT really clear. And we're also trying to make sure that we give ourselves time to complete the work we already have on our table. Any questions regarding the changes to the roadmap there? We are reviewing and trying to create a formal domain suggestion process that we'll bring back to the public collaborative once we get insight from the public, the PMO office or the project management office and our executive committee. So we really want to make sure that we make it really clear how domains get on our roadmap. So that will come back to the public probably at either the next meeting or the meeting after, once the executive committee has finalized it. Next slide, please. All right, so this is the schedule. So here we are on August 19th, ending our summer break. It is a kickoff of the goals and interventions work for social connection, elder abuse, and demographics. You can see we're really focusing on these elements first, and then we run through social connection, elder abuse, and demographics. Demographics, remember, were those grouped concepts that are sometimes part of social histories, veteran status, education level, and unemployment. And then at the end of the month, end of next month, I should say, we kick off intimate partner violence and stress. I do want to, just for the sake of clarity, reiterate that when we're talking about stress within our work here, we're talking about psychological stress, which is the same concept we covered in the spring. And then intimate partner violence and psychological stress will carry us through the rest of the fall. One little note, so as we're addressing social connection, we did carry over one diagnostic concept of relationship quality, which we'll be working on with the subject matter experts over the course of this time as well. So even though the major focus is goals and interventions, we also will be addressing relationship quality. And also we carried over a sub-concept of how to address the abuse of non-elderly vulnerable adults, because our elder abuse subject matter experts are experts in violence across the ecosystem. We will be trying to address that concept because the public was very clear that addressing the need to identify abuse in these populations was really critical, and there are many of the same processes of referring to adult protective services. So that is our very robust, very full 2-month schedule. And again, we'll be working intently over the course of the next few months, wrapping up in time to take a little bit of a break in December around the winter holidays. In the demographics section, are you scheduled to address race, ethnicity, language, and SOGI? So not at this time. So demographics is a bucket for the things we've addressed in the past. It's hardly comprehensive. Of course, we want to consider SOGI, especially with its inclusion in US CDI v2. We have considered ethnicity. The only thing I'm going to say is that race and ethnicity are not risk factors in their own right. So we already have identified a need to address minority stress and measures of discrimination and bias. And that is part of our work of focusing on the outputs of racism and the experience of racism within the health of the clients and patients we serve. So right now, we know we are committed and have, at least in the hopper, SOGI and ELL and language barriers and issues of minority stress and discrimination and bias. So when we formalize that domain selection criteria with the EC and bring it back, we'll really try to make it very clear the domains are in the hopper, what criteria considerations we have to take into mind in order to make it a formal domain. So that will all become very apparent over the next month, I would say. And we're really trying to make it clear how things get on the roadmap. Did that answer your question, Lisa? Probably that and more.
Yes, great, thank you.
Okay, thank you. A key thing to note is that just as a FYI, future thinking, really what Gravity is trying to address is things that are measurable and carry risk in the literature. So this is part of the considerations we do when things are getting on the domain roadmap, and we'll talk more about that as we go forward. Any other questions regarding the project schedule and activities?
Sarah, I just want to be grateful the last 2 years that you have so embedded the idea that everything we finally decide on has to be evidence-based from research in the literature about how to talk about which problem. I mean, we could, the people on this call could go on till the cows come home about what they think stress is or what elder abuse is and all of that. And I think the Gravity Project insistence on the evidence base really speaks to the integrity of this project. Thanks.
Oh, Lucy, that's very sweet. I think that, you know, we have our pillars, and referencing the evidence really is one of them. And I just need to give a hat tip to our subject matter experts who are the anchors and lighthouses for this work. So we are so very lucky for the collective and for our subject matter experts. And I really missed you all, even though even though we were very busy this summer, I missed you all, and it's nice to be back. So thank you, Lucy. That's very kind. Any other questions on the project schedule or activities?
Just had to get that in there somewhere because people new to the group may be really impressed how we got into ICD-10, and that's the reason.
Yes, thank you so much.
Nobody can undermine the integrity and thoroughness of what we finally decide. At least not anybody that I'm aware of.
Maybe I'll send them to you if they do. I'll be like, you need to talk to Lucy. All right. Thank you. Thank you so much, Lucy. That's very kind. It's actually a very lovely way to kick off our work, is kind of reflecting on kind of a building a vision of what standards development means when from a really comprehensive perspective, both ensuring the voice of critical stakeholders, because again, for anyone on the call, like, we're very intentional to make sure that we have representation from across the ecosystem in the deliverables and products that we create, ensuring our consensus process is followed for the collective, and also ensuring that we have evidence to guide us at all times. So thank you so much, Lucy. All right. Okay, so I think we're ready to go on to the next slide. This is just a general engagement guide. So there's not a ton of reference for this right now. So the intent of the public call is to present updates of Gravity materials and offer opportunities for the community to reflect and discuss implications. This actually I said it wasn't applicable, but this directly ties into what Lucy was saying. So whenever the community has a comment on wanting it to be different than it's presented, we really ask in any point of the process, but specifically end-to-end review process, that we want a rationale with evidence for why. So everything that we bring to the community, We do try to have rationales with evidence, and anyone who's submitted concepts knows the Intervention Council there's lots of need rationale, need evidence, need citations when we send things back. So whenever the community is making these comments, we hope for rationales with evidences also. And then we do just make sure we go back to our subject matter experts as to ground our work. Next slide, please. We just want to state that if you are new or if you're coming in and you have questions about domains we've already covered, and even elements of domains we've already covered, we do ask to take those conversations offline because they're very, very dense agendas. Even though it looks like the Sarah show, there's a lot to cover. So if you have a question about what we did in transportation insecurity or elder abuse diagnostic concepts, please just send them an email to gravityproject@emiadvisors.net, and we'll ensure that the appropriate member of the team reaches out to you. And then this is in referencing future domains. So if we ever touch upon a concept in our calls that we have yet to cover, we hope to very shortly present to you a formal submission process for domains that are in the hopper and their progress to getting on the roadmap, so everyone can know where we are. So we could just direct the public to say, yes, health literacy, it's at this stage of getting on the roadmap, right? And so everyone can reference that and make sure that we are as streamlined and as efficient as possible. Yes. Next slide, please. All right, any questions on that? Okay, next slide. All right, so this is the terminology team. These are the amazing people I spend most of my time with. So again, I'm the director of clinical informatics. Our lead terminology consultant, one of the wisest people I know, is Linda Hyde. Our community liaison and public health consultant is Asha Emanuel, just amazing, and she's really helping spearhead the work of the Interventions Council due to her community engagement work in the past. And Katja Schell is our terminology consultant. Really just, I work with the most amazing people, so I'm so grateful for spending my time with these folk. Next slide, please. So here we are. We're back to identifying. So we went with screening, questions and answers, and diagnoses. We went all the way through the process and are actively in build, and now we start back again. So we are going to work on identifying concepts for goals and interventions over the months ahead. Next slide, please. And next slide. Asha, do you want to speak to this briefly? Since this is your baby?
Sure, Sarah. So the Intervention Council, excited to work on this with a group of people that are just really close to the ground in caring for people at the community level. So the goal of the Intervention Council is to identify interventions that are critical to addressing social risk and population health. And those include clinic and community programs, as well as the necessary roles and professions needed in order to care for people. The timeline for this work, the first phase is expected to last 3 to 4 months with bi-weekly meetings, and that started in July. We have our next meeting for the Intervention Council tomorrow. And we have begun this Intervention Council work in the demographics domain, which includes educational attainment, employment, and veteran status. And that is it. Sorry, that is my son calling.
I want to give a specific mention to our colleagues at Affirm. We do have outreach to them to try to integrate their really extensive work on the flyer IG side with our terminology builds. So Charles has been submitting concepts left and right for veteran status. So integrating the work of our federal partners is always part of our mission. Is there a rural-urban dimension to the Intervention Council? Yes, there is, Lucy. And I do want to thank you for always highlighting the many different facets of what it means to be representative. Certainly, I can speak from deeply rural primary care. The resources that we have are different than other places. And I also want to speak that we also consider locations, the difference between FQHCs or community health centers and private and hospital-owned clinics, right? So these are all part of the hats we take on and off to make sure that our terminology development is as robust and representative as possible. Next slide, please. Any other questions?
I just recently saw a statistic that about 20% of the US population that might need social dimension interventions live in places that hardly have any resources, and the resources that are there are in the church basement or out of somebody's house, or generally from sources that many of us on this call may or may not know anything about. Sarah probably knows as much as anyone, but the point is that interventions just are going to vary between rural and urban a lot. So thank you for taking that into account.
Yeah, we consider that both from a programmatic perspective, but Bob can testify. I talk about that from a tech perspective as well. Like we want to make sure to build with an equity mind on all fronts, right? So like the food bank closest to my clinic is in a church basement. It's open once a month, right?
Mm.
That's where people need to go. So I hear you, Lucy. You speak to somebody who understands, who is deeply rural, and really appreciates you calling that to light. I want to highlight a question from the chat. It's important. So is the Intervention Council looking to identify types of programs or specific programs? Because we are a national terminology development program, we always develop generic types of programs unless it's aligned with the federal policy and federal policy reporting requirements. So when we built terms for food insecurity, we ensured that we had alignment with policy requirements from the Older Adults American Act or the USDA. We did the same thing with housing, but in general, we want to build as few terms as necessary to represent data, but consideration to what's necessary for reporting, and we don't build proprietary terms. So one of my, for instance, so Meals on Wheels is home delivered meals. Benefit data trust turned into benefits enrollment assistance. So in every instance, we work with private companies to ensure that we're representing the type of service offered, but we're not building proprietary terms. Tom, was that a good answer to your question?
Yeah, that was helpful. And now how would that relate to, for example, the 211 LA taxonomy, which already has a pretty substantial list of types of services and interventions?
Yeah, so
would they be considered proprietary?
Well, so what we do with our mapping to 211 LA is we map to the lowest common term that's necessary within HIT. And then from a point of implementation, the rest of the granularity would have to be represented by 211 LA.
Great,
right.
thank you.
Yeah, it's impossible kind of to imagine at this stage of development building this like the complete granularity that's in that amazing resource. So we work directly with 211s to ensure that we get kind of representative data, and we do have some folks on the call who we do that work with. So it's really trying to make sure that we can speak the same language, but I will never be an expert. My HIT system's never going to be an expert in the robust specifics of the social care ecosystem and vice versa. And this is just for health terminology development, remember. This is not anticipating possible need for that within technical solutions.
Thank you.
Any other questions? All right, next slide, please. All right, here we are. This is a very brief kickoff because we already had the big kickoffs for each of these domains at their point of time. So this is no presentation of evidence. This is presenting the mission. So next slide, please. All right, so the task for the next months is to build out the goals and intervention concepts for the screening and for the screening and only diagnosis domains we addressed in the winter and spring. So each of these domains, less than a high school education, veteran status, unemployment, psychological stress, social connection, including social isolation, loneliness, and lack of social support, intimate partner violence, and elder abuse. Over the course of we started the demographics in like November of last year. For each of those, we only built screening and diagnoses elements first, right? And we saved the work of goals and interventions for later. And later is now. So our job is to revisit these concepts and ensure that we have these comprehensive sets of goals and intervention concepts in order to create our full data sets. So all the terms we build and suggest will go into those domain data sets to partner with our screening and diagnoses elements. Next slide, please. Just a brief highlight on intervention development, and this is kind of a refresher for folks who haven't been working in interventions in a bit, which is basically like all of us, because we've been so screening and diagnoses focused. So the core of Gravity's approach to intervention development are the programs and professions critical to addressing the social risk at hand. And this is what Tom was referencing, right? So we do know that if we think about the 211 LA taxonomy, there really isn't a better resource of the programs across all domain social risk to address the needs at hand. So it's an amazing taxonomy of services. We also want to build professions. So in our past terminology development, we've built concepts such as community health worker that didn't exist before, or care coordinator that didn't exist before. So we do know there are some roles, like some people that are critical to addressing each of the different social risk domains, and we try to make sure that they're in as well. Already, from the submissions from our Intervention Council colleagues, we have other critical professions that we didn't have before. I want to specify that almost all of the professions that we identify, we then try to fold back into previous domains. Like if we miss something that's really applicable across all domains, we go back and fix it later on. Like if we had missed community health worker, for example. And then for every single social risk, there are programs that are common across all of them, like community area agency on aging or the community action agency, right? So there are programs that are really, really critical to addressing social risk comprehensively, or referral to community resource program, right? So each of these kinds of concepts are always on the sets, and we just roll them in from domain to domain.
Sarah,
Again, yeah, hi.
I appreciate the alliteration of programs and professions. I was wondering whether you've already discussed and probably discarded the notion of community workforce participants or just workforce participants instead of professions.
I like that because maybe that would better represent the lay folk who are so critical, right?
Yeah, a lot of volunteers.
Yeah, I hear you. And honestly, I think, yeah, so I acknowledge that. And I'm not actually a fan of alliteration. So I think we'll take anything that makes it clearer and is more comprehensive, right? Because again, yeah. So Lucy, I really appreciate that comment, and I'm going to take it to heart, and
Okay.
We'll try to make sure that represents, because again, many of the pros are volunteers. We had some concepts of peer support that are coming across some of our work right now in our current domains from the Intervention Council, right? So professions might not be the appropriate term, and I'm grateful.
Yeah, peer support groups, beginning at cancer and spreading out into all known problems and dysfunctions and whatnot. Terribly important.
I love it. I love it. So it might be additive to professions, and we will, but or its own thing, or it might encompass it. But I think that your point is very well taken, and you have tons of plus ones from people in the chats. So great. Thank you, Janice. Hello, Janice. All right. I feel like I haven't seen my friends all summer. It's like back to school. All right, so I do want to state, again, we were just talking about this with Tom. So whenever we build terminology within Gravity, there's really some important things to know that we're always keeping in mind, in addition to the evidence, right? So the evidence is always in hand, but we always anticipate aligning with federal reporting requirements. So even if the mapping is not within scope right now, So even if like we're not doing that work, we don't want to build dissonant to the concepts in federal reporting requirements and policy, because that would be, disable future semantic consistency. So we build with policy in mind, and we build with 211LA in mind, really recognizing their expertise as the encoding of human services and the vast work of all the heirs, affiliated members to curate this good set of terms. We always kind of think about those two things and make sure we're building in kind. The next thing to know is that all programs and professions are then integrated into the Gravity Project intervention structure. And this is on the next slide. So next slide, please. So just a grounding and a refresher, right? So this table is available on the Confluence, but way back in the beginning, 2 years ago. Oh, great. Hi, Hasna. Way back in the beginning, 2 years ago, really to wrap around our work, and this is really in the absence of a public and open taxonomy of programs, right? We had to develop definitions for the activities that wrapped around our programs. So we worked very, very closely with colleagues at SNOMED CT, and some of these terms we had to actually come up with ourselves, and again, reference, so we had to define coordination. We referenced AHRQ for that term, but whenever we have a program or a profession or a community workforce member, these are the terms that we align with it. So it is education about SNAP, which is a food security program, or provision of housing voucher, which is a housing program. So all of the programs and professions that we collate and collect together are then plugged into this intervention structure with these common definitions, and that becomes the base of our submission to SNOMED CT. And this is again just so that we know what we're saying when we talk about X. A specific highlight to the evaluation of eligibility term, because it's kind of a complex term, but this is for any instance where there is labor undertaken by a member of the ecosystem to assist a person in determining eligibility.
So where does peer support fit here?
You can imagine referring to, or you can imagine possibly in the future offering it, right? So right now you might refer to a peer support program, right?
Yes, I guess I'm wondering about offering it.
Yeah, so that actually is one of the things we're trying to figure out.
Okay.
So it might be provision of peer support, right? But then that is just the SNOMED side. So again, what Gravity is trying to think about is what's in its charter. And there's all of the representing that labor in claims and accounting for care that we're trying to figure out what we do as well. So we just heard two terms, provision of peer support and referral to peer support program as possible applications of that process here.
So we'll see a final proposal that includes the term peer support somewhere, so we know where it lands.
Yeah, exactly. And
Okay.
we're just beginning that process. So the term I just brought it up. We just saw for the first time today. It has to go through the kind of like development phase, but everything that we just said is going to land on a spreadsheet that will be available to the public for review.
Great.
Okay. Next slide, please. All right, so the goals development, the core of our goals is representing the desired state when one has a social need. And you can see I've switched here from social risk to social need. We always follow the Laura Gottlieb and Hugh Alderwick lexicon of social needs, that social determinant, social risk, and social need perspective. We are working toward describing the work of social care as the ecosystem we work within, of course, as we're collectively trying to meet social risks and social needs, but social need is the thing the patient says they want to solve, right? So when we're talking about goals, it's important to use that term. And again, we will get more into peer support and all the details of that in future work. I can't manage the chat right now. So we'll try to capture, and education would be a facet of peer support too. And the question is whether we have to collectively evaluate how peer support fits in. We're not ready to do that yet. I just brought it up as an example of a possible missing profession But it will come back to the group as it's like after it cycles through the interventions council, I promise. In the past, the Gravity Project has taken the task of building macro terms or macroscopic terms representing protective factors or the antithesis of the problem. And I have some examples here. So when a domain has subdomains or plateaus that mark progress, we build to those too. So you can see food insecurity as the problem. The meta goal, the biggest goal might be food security, right? But within that goal is so complex because if we remember the facets of food security, it's stability, safety, quality, quantity, cultural acceptability. So all of those concepts have to be met for someone to be food secure. So it might not be, you might not ever reach that goal for that person, or it might not be practical to have a measurable goal of achieving food security. You might want to drill it down to things that are closer to the patient and these subdomain plateaus. Like maybe the goal is having adequate number of meals and snacks daily. Maybe the goal is having adequate quality meals and snacks, right? And the same thing happens in the housing world, right? So to move from homelessness to stably housed is a massive leap, right? But maybe you can imagine moving from homelessness to homeless and you're sleeping safely, right? So when we're building goals, and these are all things you've seen before, right? The idea is to identify the macro goal, but also these steps or these plateaus that mark progress, right? Because whenever we're doing care coordination, there's 1,000,001 social workers on the call, but we want them to do things that seem attainable. And then this would be the term, and imagine this underneath it, you could have all kinds of descriptive text and free text about what that actually looks like for the patient, but this is the approach we've taken so far. So we're going to mirror this in our work with education, less than a high school education, unemployment, veteran status, social connection, et cetera, right? Building that macro concept, what that looks like, and then all the different sub-elements. Any questions here? Great, okay. I want to specify, we have to build things that are unique. So it might be that we don't, maybe there isn't a need for a provision of peer support program, as Rita and Lisa were talking about, because maybe the referral to the peer support program is the unique pathway. And then once you're in it, you're doing coordination, education, counseling, assistance, the same way you do with any of the other roles, right? So that's something we'll flesh out with the Interventions Council. And if anybody wants to help do that, that sounds great too. We just want to make sure that we're not building extra terms that make things more complex, because our goal is to keep things pretty simple. Thank you, Michelle. So if you want to, if you want to send, if you have submissions within the Pathways Care Coordination Model to identify, to align with those standard goals, we do have the submission link up above, and maybe one of my colleagues can drop it in again. We really appreciate any already standardized methodology out there in the ecosystem to be formally submitted into Gravity so it can come through the process. And if you need assistance, you just want to send an email regarding that, that was wonderful. But we would love that to have the Pathways Care Coordination Model formally integrated into the Gravity work. All right, for instance, we the Camden Coalition, the Camden Cards, we do try to reach out to the experts in the ecosystem. We feel like that IC has an amazing group of folk as well. Next slide, please. This is my little, I did these for Lucy. Lucy, I was thinking about you. I spent time doing word clouds for Lucy Johns, right? So
feelings mutual.
I know. So just an example of how this starts to look. So these are some of the terms that are already in the hopper. So less than high school education, you see basic skills, adult education center, high school completion, English language learning centers. So all of that, right, are in there as programs and different elements that will be aligning with less than a high school education. Again, these are all, we try to formalize them, right? So if it's federally funded, we try to keep our terms in kind across federal funding programs. And then unemployment, again, basic skills comes into mind there as well. When you add vocational rehabilitation, unemployment assurance, et cetera, and you all are humoring me with my little workers' rights fist here. You can tell I'm a social justice community worker at all times. So this is just an evolving work. So this is just to keep it interesting. So these are examples of the terms we're building together over the course of the next months. Next slide, please. Quick highlight of our social connections SMEs, amazing group of folk. Edward Garcia, Dr. Julian Holt-Leinstead, Dr. Matt Pentel, and Dr. Carla Persinotto, brilliant. We already are meeting weekly with them. Next slide, please. And then a nod to our brilliant elder review subject matter experts as well, Dr. Rana Ciarno, Dr. Jason Burnett, Dr. Zach Gasumis, and Dr. Tony Rosen. Next slide. And any questions regarding terminology, I'm now going to pass off the mic to my colleagues. We spent a lot of time. We have a policy update and a tech update for the next chunk of the call. Thank you, and welcome back to Terminology Build. We are going to have a good fall. Now it's Mark.
Thanks, Sarah. Next slide, please. So I went back and checked, and actually the last time that we all met together was on July 8th, the day before ONC released the final version of the US CDI. So many of you will have already heard this news, but just in case, the Gravity SDOH data elements were added for nationwide interoperable exchange. So that's a woohoo moment. They, the four of the 6 that we submitted are listed there: assessment, goals, interventions, and problems, health concerns. Outcomes was not added, consent was not added. I'll get to those, what we're doing about that in a few more slides. So just a huge gratitude and appreciation to the entire Gravity community. It really did take a village to make this groundbreaking contribution. So many people contributed in so many ways, and we really, it's really pretty amazing. There were other related data elements that were added as well that sort of reinforce the SDOH data elements. So sexual orientation, gender identity were mentioned earlier. We did get those 2 data elements added to US CDI version 2. So they are now a part of version 2 for interoperable exchange. Also, going from just clinical care team members to all care team members. So this would include family caregivers, community and social caregivers, the whole range of caregivers. So this helps to enable the interventions that Sarah was just talking about by having interoperable exchange of all care team members. So just an amazing, amazing contribution. And to the next slide, I thought it might be worth pausing to think just how much has been accomplished so quickly. In my world of policy, you do not normally cover this kind of territory in just 2 years, but we did. So the work on the first domain was July 2019, and the release of USCDI version 2 with those data elements was July 2021. That goes through all the process of public comments, all the development, everything. And it's true that we have testing yet to come, but the infrastructure is now out there and in place for use, for pilots. It's just a huge lift. So not only thank you to the Gravity community for making this happen, but thank you so much for making it happen so quickly in the midst of a pandemic, and so that it could be useful for even as we are trying to dig ourselves out of a pandemic. Next slide, please.
Actually, Mark, it was a wonderful distraction to be doing this during the pandemic. And I think you could make an argument that the pandemic helped us because we were all chained somewhere. We couldn't be running around and going to meetings and doing all that stuff that we usually do. We could concentrate on this. It really, I would argue that it really helped.
Thank you, Lucy. You are right that it made time and energy available that might not have otherwise been there. It also highlighted, it magnified the need, for what the Gravity Project is doing, and people could see it every day. It was in the headlines every day. What people could not do because this was not in place for remote care to try to help people in communities. So yes, and the Gravity Project was able to work with, harness, steward that perception and the new understanding of need to get this moving forward quickly.
We really leveraged the time slot that opened up for our work. You leveraged it.
That's right.
Thank you.
Well, we all did. Thank you. And that's sometimes we have that gift to leverage. So I'm grateful for it. As you've heard from me before, USCDI is an annual process. So we've just seen the release of version 2. At the same time, ONC is already taking nominations, submissions for version 3. So in that, I happen to sit on the USCDI task force of the Office of the National Coordinator, and the task force co-chairs invited Evelyn to present the Gravity Project's thinking about version 3 and priorities and recommendations that the Gravity Project might have to the task force for version 3. That meeting occurred on July 27th. The task force members were very engaged. They were very interested in what the Gravity Project was thinking, how we thought the work in V2 could be used, what the opportunities were, what the challenges were. For example, testing, iteration, making it real. They also asked the task force asked how they could advance the Gravity Project's work in version 3, and so we gave them some ideas. Submissions are due on September 30th. I'm working on a draft for the PMO's consideration and for the Gravity process. A quick snapshot, if you'll go to the next slide, please. This is what Evelyn mapped out as a potential way for the USCDI task force to think about it. And I will, everything that's in the black font, you've already seen before. That was submission 2 from the Gravity Project. The domains, under the domains column up to in the black font, what I've labeled now as data elements, but at the time we were thinking of them as activities. Again, the social determinant of health clinical care implementation guide, and the code systems and the value sets. So I'm going to start with the additions, starting with the domain. Because ONC structured the data elements around the activities, so we're able to add domains whenever the Gravity Project is finished with its work and the coding systems approve that work. We can fit it in. It does not need to wait for a formal addition by ONC to USCDI V3, because those codes, say the LOINC codes for assessments for a new domain, will just come in under the existing data element assessments, SDOH assessments. The same is true for all of the data elements that have already been added there in the black font. So that you've already seen from Sarah's presentation and terminology, the blue list and under domains are items that we've already talked about as trying to add for the coming year. We recognize the importance of addressing racism, discrimination, bias. We recognize that is a complex domain. Probably will be broken up once we hear from the community, and the subject matter experts will most probably require more work than getting to mid 2022. But it's on the list, so we let the USCDI task force know that we were aware, the community is aware, and is thinking about it. Moving over to the data elements column, we will resubmit outcomes and consent, and then we will lift up data aggregation, billing, and health insurance as additional column data elements, column activities the things that are very important in order to make the social care and the addressing of social need possible in the ecosystem. And then going over to the first column on the left, the implementation guides, we can broaden the implementation guides using those data elements and domains. So social care, quality measurement, population health, public health, directory services, and research. They will build upon much of the work that Bob Dieterle has already led on the clinical care implementation guide. So it's not rebuilding from scratch for each one of these, but it is it's more than tweaking, but it is taking that good groundbreaking work for the implementation guide and putting it into other implementation guides as well. It's not that all of this has to be done by September 30th. Instead, we believe that we will be able to have it ready by June of 2022, and thus it is right for us to submit it on September 30th, 2021, because we think it will be ready, much the way we did with the domains and activities for version 2, which were indeed ready by June 2021. So
Mark,
that's
could you elaborate on data
that we laid out. Yes, Lucy.
Could you elaborate on data aggregation? What's going on with that? Is that the whole research domain? You know, within an academic perspective, is that what is this about?
Right. So I'll let Bob speak to it, but a quick intro to that. It's what he has already been covering on the implementation guide. It's a way of taking data that is not just one individual's data, but combines it and aggregates it for different purposes. How best to do that may involve different implementation guides, but the function, the activity, the data aggregation will be core to many of the different implementation guides. Bob, do you want to jump in and add anything?
Yeah, I think it's important to take a look at these different implementation guides in light of other work that's going on at HL7. The work that's being done on quality measurement, for example, or the work we're proposing here is probably going to be rolled into work that NCQA and Gravity and CMS, and Da Vinci and CMS have already done around the ability to report quality measures, okay? And they have a standard for that, and it seems to make sense to roll it in. The work around directory services, there's work that's being done based on the work that's coming out of the Fire at Scale Task Force. So we'll be looking at how we can take advantage of the work that's ongoing at HL7 for directory services. We're looking right now at the idea of population health and research as being based on aggregated and potentially de-identified information. And I say it potentially, it depends upon the use case. And so to address your question, Lucy, what we're doing with aggregation is a way to go and aggregate various cohorts of individuals, okay, whether it's around a particular service that's been delivered, a particular diagnosis that's been made, or a particular payer that is supporting them. And then being able to turn around and, as part of the next iteration of work, determine whether we provide that as patient identifiable information, as patient re-identifiable information, as de-identified information without the ability to re-identify, or potentially as completely aggregated information where we're looking like quality measures and creating numerators and denominators. In other words, the denominator are the number of individuals in this cohort, and the numerator are the numbers of individuals that have a particular characteristics within that cohort. So that's kind of the work we're doing around data aggregation. I think as we start to land this by working with other accelerators and taking a look at how we can expand what we've done on the current implementation guide, we'll have much more that we can come back to you with as far as discrete approaches. Make sense?
Thank you. Yes, I started in my own mind with de-identification, and it's always a lot more complicated than I originally think. So thank you.
Yeah, and de-identification has this interesting characteristic that it's basically use case specific. And so we have to think in terms of the use cases that we're de-identifying for, because if a use case requires a particular demographic element, we have to include it or we can't use it for that particular use case.
Yeah,
So
exactly.
Exactly. So this is a really complex topic when we get to de-identification that we'll have to address.
And to that last point, Lucy, sometimes data aggregation does not include de-identification, if that wasn't clear. So you may have a business associate combining the data from two different covered entities in a private and secure way, but it's keeping it identified in doing patient matching. So as Bob says, it depends on the use case, all complying with HIPAA.
I can't wait to see those use cases. We're talking about a book of use cases. Okay.
And we'll certainly
I think I pass off to you, Bob.
Yeah, that's fine. Let's go on to the next slide, please.
Sorry, I have a question. How do we contribute to the content or review what you're planning on submitting? I'm asking because AHIMA is getting ready to launch a health literacy initiative, and I know a couple of people at AHIMA that probably would want to contribute or participate. How would that happen?
We'll do it kind of as an overview on this call. We'll do a deeper dive on the technical advisory call, and we'll get really down into the weeds around these use cases on the call that we have every Wednesday afternoon around the implementation guide. So there'll be several different ways that you can participate in both helping us set direction and providing feedback on the decisions we're making. Okay?
And if I'm hearing, this is Mark, if I'm hearing the question correctly, it sounds like you're also offering help around the terminology work that might happen with health literacy, and that's something that Sarah DeSilva would pick up as well. So make sure to, as always, to reach out to, I think it's Gravity Project at emiadvisors.net. Express the interest, and the good folks at EMI will make sure that the connections are made.
Okay, I will give their point person the contact information. Thank you.
Hi, Lolita.
You're
It's
welcome.
noted, and we should just chat.
Okay, thank you.
Okay, next slide, please. Next slide, please. Next slide, please. Thank you. So this is the timeline for the technical roadmap. We haven't talked for a while, so we'll bring people up to date. We did complete and publish the initial SDOH clinical care implementation guide. It is broader than just clinical care. We didn't rename it because renaming things at HL7 becomes quite an interesting process. But it supports interactions between providers, payers, community-based organizations, coordination platforms, and government entities. It touches on the ability to connect with the patient or client, depending upon your orientation, but we're going to elaborate on that in the next version of the implementation guide. So we have published it, as we show here. We're at a point right now where we're starting to identify what we're going to do for the next version of the implementation guide and other work that we're going to do in association with other accelerators. We're also looking for feedback based on pilots on whether there are things that we have to modify in the existing implementation guide. We built a very robust reference implementation to test it, but once you put it into practice, you always learn something. And so we have a couple of vehicles to address changes that are necessary. If they're purely technical corrections, we can do a technical update. If they require something more than that, we're able to do what's called an STU update to go and make significant changes, but not rewrite the implementation guide. And then we'll have an opportunity as our target in January to go and ballot a next version of the implementation guide that'll incorporate a number of new features. Next slide, please. So this is the publication information. It's an ST1, standard for trial use level 1. That link will take you directly to the published version of the implementation guide. We also have a reference implementation that is continuing to be updated. This is a link to it. And we will test the updated reference implementation and the implementation guide itself, as well as some of the features we're considering for the version 2 of the guide at the Connectathon in September. So please come join us at that Connectathon. If you're bringing technology to the table to test, and this is really focused on testing this time, not so much on education, we do have the ability to go and work with you in advance of the Connectathon to make sure that we can communicate, to make sure the exchanges are working well, basically to set things up so we can be incredibly effective during the 2 days of the Connectathon. Next slide, please. As a reminder, the current implementation guide supports the ability to automate an assessment process, starting with a link-coded survey and going all the way through to producing observations, which are questions and answers, as well as health concerns that are basically derived from the answers to the questionnaire. We have the ability to support, as we said, the health concerns. We can have them pre-coded with ICD-10 and Summit CT to the extent there are codes available. We have the ability to support and exchange link and Summit CT coded goals. We have the ability to create interventions or referrals based on Summit CT, CPT, and HCPCS. We can also include in that link coding. And then we have the ability to document what happened in a closed loop referral using the procedures that can be coded with Summit CT. So the work that Sarah's doing right now on interventions and the work that was done, for example, on food insecurity on interventions, we can go and document and exchange as part of a closed loop referral process with the service provider in the community or with other providers. So it could be provider to provider, it could be provider to community, it could be payer to community, and it could be community platform to community-based organization. So all of those are supported by the current implementation guide. We have the ability to pass consent. We've talked about that before. In this case, we're only focused on one aspect of consent where we actually exchange it as part of our workflow, and that is where we have a covered entity working with a business associate to exchange information with a non-covered entity. So we have the ability to define a patient-directed consent in that case. We'll do more on the next version of the guide, assuming we've, shall we say, moved the ball forward at ONC and HL7 regarding data tagging and consent. And then we have the basic ability to aggregate individuals, create cohorts, but at this point, the guide doesn't support de-identification or de-identification, re-identification, or true aggregation, meaning aggregation by doing numerators and denominators like we do with quality measures. Next slide, please. We did attend a CMS Connectathon. We had a socio-determinative track there. It was July 20th through the 22nd. There were roughly 40 individuals that participated, representing about 20 different organizations. That information is available on the Confluence site. You can look at the track information, including the track summary at the end. There is, as we said, another Connectathon in September, the 13th through the 15th. Please sign up if you have not, and please bring codes to test. This is really going to be much more a testing of code Connectathon than an education event. We can also declare participation in Gravity's track. We have a link there for that also. Next slide, please. I think this may be the end. Yeah. So at this point, let's see, do we have any questions?
We do. We have one starting with Matt. So will the SDOH directory IG work be done in conjunction with other standards groups, IG Direct Trust, HL7 Fastfire Directory, etc.?
There will be an open directory call. It's under patient administration. It should be on Thursdays. We had a bit of a problem in getting it set up for this week. It should be available for next week, and it'll be on the HL7 calendar. So anyone that wants to participate can participate. That includes direct trust, is based on the Fire at Scale task force and the directory work that they have done, but is also based on, I think we see down here later, VHR, which is some of the earlier work that was done between ONC and the Federal Health Architecture Group, as well as the work that was done in Da Vinci around PlanNet to meet the CMS interoperability rule requirement. That will all be taken into account as part of the work. The ultimate goal there is to produce 3 implementation guides, one to update VHDR based on work that was done in PlanNet, to localize it to the U.S. and to take into account some additional things that we discovered, as well as expanding the scope of what an endpoint is to include fire endpoints and things like trust frameworks. That's one guide. Second guide will be a standard guide for any of the federated environment to support to query an endpoint. We want that to be uniform across all implementations. And the third guide will be focused on attestations and validation of information in the validated directory. So those are the 3 guides that we'll be creating in that work group. What else do we have?
Bob,
Yes.
question. This is Lucy.
Yes, Lucy.
Given, as you've just clearly implied, how much work has gone on over the years with respect to directory, I guess I'm wondering, with respect to this HL7 work, does HL7 reach out to these groups to let everybody know about the work group that you're setting up? Or do you just hope that people like Matt or me or Lisa or others on the call who know about other efforts just hope that we pick up on this and are able to attend? Is there formal, is there a way, is HL7 thinking about, we need a national directory, not these siloed efforts anymore? Is that going on?
Yeah, it is. Once we get the time set up properly, hopefully within the next day or 2, we'll send an announcement to the listservs that we're starting this work. I already presented this at the Direct Trust meeting you had, about a month and a half, 2 months ago. And we'll announce it through the Fire at Scale Task Force, and we'll announce it through the work we're doing here in Gravity. Okay?
That's great. And do you have to be an HL7 member to participate in this new work group?
No, you do not.
Thank you.
It's open to anyone. If you wish to go and vote on, meaning vote on the ballot for these implementation guides, you either have to be an HL7 member or you'll have to pay a fee. But to participate in the work group, no, it's open for everyone.
That's important. Thank you.
Yep, you're welcome. Is the current implementation guide based on Fire R4? Yes, it is. It's based on Fire R4. It's also based on the current version of US Core, which I believe is 3.1.1. I think that's it. Is there anything else I have not answered? Or does anybody else have questions? Okay, if not, then I'm going to turn it back over to my colleague, Sarah, who's going to wrap us up.
Thank you, Bob and Mark. Back to me for the closeout. All right, next slide, please. So if anyone is new, I imagine that you might feel like you're just drinking from a fire hydrant. So Gravity might have taken a little bit of time off, but we are doing a lot of things all at once and collectively accomplishing great things. So if you ever want to catch up on everything we've done in the past, again, the Confluence is I will state very plainly, overwhelming bevy of information of the 2 different work streams, including our policy initiatives. You can find our data principles there that guide our work. You can access all of the resources we've talked about in the call today. You can catch up on past work and future work. You could submit concepts for the domains coming up. So if you're new, go ahead and access the Confluence, or just write us an email. So I have some skills. Responding to emails is not one of them. So if you want to schedule a one-on-one or an orientation to the project, write gravityproject@emiadvisors.net, and then it will become part of our regular meetings that we have to make sure we're following up with our stakeholders. The major work to do, of course, from the terminology side is to submit those concepts. Again, those programs and professions and community workforce roles. Lucy, I did not forget. Regarding social interconnection, elder abuse, and demographics, this is the focus of our work for this next 2 months. And then at the end of September, we pick up intimate partner violence and I'm trying to remember the other one that and psychological stress, right? We are so grateful for the collective. You know, we ground our work on social justice principles. We collectively achieve great things. So thank you so much. Next slide, please. As always, join us as a committed member. We regularly communicate with anybody on our email directory, on the Tuesday emails that our amazing Sarah Bahal leads. The public collaborative is every other week on a Thursday. You can submit those data elements. You can find us on social media, which we obviously are, I'm going to be honest, we're not actually particularly good at because we're so busy. You can always help us find new sponsors and partners, and we're so grateful for your participation. You can again find Bob's work at the SDOH Fire IG on from 3 to 4 EST via the HL7 calendar. Any other questions before we close out the call? Welcome back. Letting newbies know that some of us who've been participating for a while are still running to keep up, but it's all going to be mutual recognition of value. Fire hydrants ahoy. Thanks, team. So this is our PMO. We're always available for you, and we're so grateful. And we will see you in 2 weeks. Thanks, friends.
Thank you. Bye.
Thanks. Bye-bye.
Thank you.